Melissa. And yes, I'm Gretchen Forsell, Project Director for the National AHEC Organization's National Training Center HPV project, and we're glad to have you all here today. We're especially glad because we're looking into a topic that most people don't want to talk about, don't know anything about, and really it is extremely important to realize what the HPV vaccine can do. So we'll talk about that in a little bit. Thank you for starting to answer our pre-polling questions. We'd like to know a little bit about what you know about HPV currently and some other issues, and this helps our presenters to sort of see what kind of audience we have. Of course, evaluation is very important, so please try to do those. At the end, you'll also see some questions of this nature to answer. But we're very excited today to have an outstanding speaker to talk to us about HPV, its implications, vaccination, etc., and then more importantly of all, to talk with an anal cancer survivor so she can share her story and the implications that it has had and the work that she is doing to battle this, this disease. Additionally, we have, as Alyssa told you, some resources that are available that we want to share with you, and we particularly want to highlight one, which is HPV Free Toolkit from the state of Nevada. We are very pleased today to be sponsoring this webinar along with our AHEC, High Sierra AHEC, located in Reno, Nevada. They normally serve a 6-county area, but in our project for the last 6 years, they have been instrumental in doing HPV education throughout the state of Nevada and adjoining states. And we are very proud of the work that they have done, and more importantly of all, that they reached out to us to not only provide information on what they wanted to do within their own state, but really to reach out and provide this valuable information to the rest of the country. So we're glad that you're all here today. This webinar will be archived, so information will be available for you to share with your colleagues who are unable to attend today, or if you would like to watch it again or have access to working with other groups or even student groups who would be interested in the information. So there's a lot of ways that you can take advantage of this, and if you've missed it, make sure that others can see what it has to offer. Our webinar today does include continuing professional education credits for physicians and nurses. We also, you can also, if you're not a physician or a nurse, you can also go to the organization that provides these credits, and you can complete the registration process to get the certificate and use those for other credentials that you may have that allow you to use either physician credits or nursing credits or just have a standard certificate. If you're unable to do that and you just, like I said, need the standard certificate, you can always reach out to us and we will be happy to provide that. The National AHEC organization has been part of this CDC project for the last 6 years to improve vaccination rates across the country. NAO is a membership organization that supports and advances the AHEC network to improve health by leading the nation in recruitment, training, and the retention of a diverse workforce. We have a network of AHECs, over 300 across the country in 44 states. They're affiliated with multiple community-based providers and academic institutions, and you would probably be surprised to know that there's an AHEC very close to you. They do work with Pipeline to get students and young people and displaced workers interested in becoming health professionals, work with current health profession students who are receiving education in all sorts of professions, from medicine all the way down to community health workers, all inclusive, to get those people to train in rural and underserved communities, and then more importantly, support people like you who are health professionals generally working in rural or underserved communities and you're unable to get to trainings. And especially with COVID-19, we all know in-person trainings are at a minimum, so it gives us a great opportunity. So there may be an AHEC near you. Please feel free to reach out to them. The presentation is jointly sponsored and provided by the Postgraduate Institute of Medicine and the National AHEC organization. And for disclosure basis, we have provided the disclosures that the accrediting agency has noted. Those are available to you and have been duly noted. So with that, I'm now going to turn it over to Amanda Aragon from High Sierra AHEC. She's going to be introducing our speakers and letting you know a little bit more. But again, we want to thank High Sierra AHEC and their director, Andrea Gregg, for the great work that they have done throughout this entire project, and especially in bringing these folks to us today. I know you're going to be in for a real treat to hear about this important disease, the vaccination, and many of the challenges that are there. So with that, I'm going to turn it over to you, Amanda, and feel free to introduce our guest today, and we'll get started.
Awesome. Thank you, Gretchen. I'm actually going to kick it off. My name is Dana Roscoe, I'm Program Manager at High Sierra AHEC, and I will have the honor of introducing Dr. Romesser. Dr. Romesser earned a combined bachelor's and medical degree at Boston University. He studied at the NCI as a Howard Hughes Medical Institute and National Institutes of Health Research Scholar. He completed residency in radiation oncology at Memorial Sloan Kettering Cancer Center, where he was the chief resident. He is currently an assistant professor in radiation oncology at Memorial Sloan Kettering Cancer Center and a physician scientist with an interest in developing novel radiation sensitizers for gastrointestinal tumors. He is a member of the NRG Oncology colorectal and non-colorectal committees and the NCI Rectal Anal Task Force. His work has been published in Nature, Science, Cell, Lancet Oncology, Clinical Cancer Research, International Journal of Radiation Oncology, and Biophysics and Cancer.
And my name is Amanda Aragon. I will be introducing Lillian. So Lillian Kreppel is a cancer thriver, public speaker, entrepreneur, and change maker. Over the course of her extensive career in both health and wellness and hospitality, she has created successful marketing strategies, developed public relations and business plans, and has supported sales initiatives for multi-million-dollar branded corporations. An anal cancer diagnosis in 2017 became the catalyst for her to combine all her expertise and skills. She has since become a powerful warrior, activist, and one of the few relentless pioneers advocating for the prevention and treatment of HPV and anal cancer. She is known as a passionate and persuasive speaker with an unparalleled sense of humor and infectious personality. Her goal is to inspire others with her personal journey. And now I will hand it off to Dr. Romesser and Lillian.
Great, thank you very much for that introduction, and it's an honor and a pleasure to be here and to be working with the National AHEC and the High Sierra AHEC, two excellent organizations working hand in hand to provide the necessary patient and provider education that really drives forward-thinking care here in the United States. So with that, I think we'll hand it off to Lillian after to take over.
Yeah, thank you, Dr. Romesser. Thank you, Amanda, and I'm so happy to be here, and I'm happy that everyone is here to watch, and I'm really excited to present. A bit of trouble with the video, but we're going to come back to that later. Moving on, what I want everyone to get out of this presentation, or right up here on the screen, learning objectives, to understand the burden of HPV disease, define the importance of the HPV vaccination for cancer prevention, appreciate the rationale for vaccinating youth at ages 11 or 12, understanding the CDC recommendations to vaccinate boys and girls, and obtain useful and compelling information about the vaccine to the parents, guide practitioners to locate resources relevant to current immunizations practice. This slide, the National HPV Vaccination Roundtable, houses a wealth of information that you can access. There's a website at hpvroundtable.org, action guides, and you can see you can find out all the information there. Moving on, okay. So HPV is a public health problem. HPV is a common infection. 80% of us will be infected at some point in our lives. 14 million individuals a year are infected in the U.S. HPV affects men, women, boys, and girls. The problem is, it's important, this is the problem, it's important to know that HPV affects men and women. This infographic from the CDC represents impacts of HPV. What we see the most often is cervical cancer. However, HPV causes nearly all cases of cervical precancer and cancer, but what is less known is that HPV also causes oral pharyngeal cancer, which is cancer of the base of the tongue and the throat. This is in men and women, and this cancer is increasing in frequency, as we'll see in a later slide. HPV causes 7 unique cancers: mouth, cervix, vagina, vulva, anus, and penis. Men and women can get cancer, like I said before, at the base of the tongue and throat, and anal cancers. Men also get penile HPV cancer. HPV causes 60% of the penile HPV cancers. The HPV attributable cancers and prevention. Together, we can prevent over 30,000 cancers each year. In women, HPV infection can also cause cervical, vaginal, and vulvar HPV cancers, as I mentioned in the earlier slide. HPV leads to nearly all cases of cervical and anal, 70% of oral pharyngeal cancers, which affect the base of the tongue and back of the throat. HPV, multiple impacts on public health. Take a look at the chart. Oops, sorry. Take a look at that. The HPV vaccine schedule and dosing. Here's the chart listing the when you're starting to take it early, ages 9 to 10, then on time, 11 to 12, late, and then late, ages 15 to 26. 3 doses. So you see the different doses for the scheduling. In this slide from the CDC, routine and catch-up vaccination, you can read there. HPV vaccination routinely recommends at age 11 to 12. You can actually start at age 9. And catch up on HPV vaccination recommended for all persons through age 18. 2 or 3 doses series, depending on the age at the initial vaccination, age 9 through 14 at initial. 2 doses series at 0, 6 to 12 months, minimum interval, 5 months. Repeat dose if administered too soon. Age 15 or older at initial vaccine, 3-dose series of 0, 1 to 2 months, 6 months minimum intervals, dose 1 to dose 2 to 4 weeks, dose 2 to dose 3, 12 weeks, dose 1 to dose 3, 5 months, repeat dose if administered too soon. If completed valid vaccination series with any HPV vaccine, no additional doses are needed. And then you have your special situations below that you can take a look at. Immunocompromising conditions like HIV infection, history of sexual abuse, pregnancy. Should adults aged 27 through 45 years be vaccinated against HPV? HPV vaccination provides the most benefit when given before a person is exposed to any HPV. That's why the CDC recommends the vaccine at ages 11 to 12. It's also recommended through age 26 for everyone if they didn't get vaccinated when they were younger. Moving on, HPV vaccination provides the most benefit when given before a person is exposed to any HPV. That's why the CDC recommends it at ages 11 to 12. Again, it's recommended through age 26 for everyone if they didn't get vaccinated when they were younger. Also, you can get it, also the new guidelines are up to age 45. And then you'll see some of the patient's questions. Most sexually active adults have already been exposed to HPV, although not necessarily all of the HPV types targeted by the vaccination. So at any age, having a new sex partner is a risk factor for getting a new HPV infection. People who are already in a long-term mutually monogamous relationship are not likely to get a new HPV infection. HPV vaccination prevents a new HPV infections but doesn't treat existing ones. So HPV vaccination reduces cervical precancers. Women have seen dramatic decreases in high-grade cervical lesions in the U.S. HPV vaccination reduces oral HPV infections. Research has found an 88% reduction in oral HPV infections among young adults who received at least one dose of the HPV vaccine. HPV vaccination is most effective during adolescence, as you can see from the slide. Recent research found that vaccination was significantly more effective against cervical precancers when given at younger ages. Now, there was a study from Scotland that measured the effectiveness of the HPV vaccine against cervical precancers. Look at the chart with the ages and compare the effectiveness rates. Younger age at immunization was associated with increasing vaccine effectiveness. 86% for CIN grade 3 or worse for women vaccinated at age 12 to 13, compared with 51% for women vaccinated at age 17. Women age 18 and older only had 15% protection against CIN3. There's evidence of herd protection against high-grade cervical disease found in unvaccinated girls in the 1995 and 96 cohort. This evidence demonstrates that vaccination at younger ages provide greater protection. HPV vaccination can prevent cancer. In late 2017, researchers published one of the first studies to track vaccinated versus unvaccinated women's HPV cancer outcomes after 7 years. Over 9,500 vaccinated young women ages 14 to 17 were compared to over 17,000 unvaccinated young women ages 14 to 19. After the 7th year, no women in the vaccinated group were found to have an HPV cancer. In the unvaccinated group, there were 10 cases of HPV cancers. This is the first intention to treat trial evidence that vaccination protects against invasive HPV-associated cancer.
And just remember, it takes time for the cancer to develop, so it's likely that that study over time is going to become even more positive.
That's right. Thank you, Dr. Romesser. Cervical cancer is preventable. It was once the leading cause of cancer deaths among women in the U.S. 90% of cervical cancers can be prevented with the HPV vaccine. This vaccination has the potential to eliminate cervical cancers. We have seen significant decrease in cervical cancer cases. Can you imagine the improvement to millions of women's lives who may not face an abnormal PAP result because they were vaccinated against HPV? HPV vaccination is safe. Over 100 million doses of the vaccine have been distributed in the U.S. since it was licensed. Near real-time data monitoring continues to show the vaccine is safe and effective. There's over 270 million doses which have been distributed around the world since 2006, with over 100 million distributed in the U.S. HPV vaccination lags behind other childhood vaccines. We're failing to protect our children from future HPV cancers and precancers. As with all approved vaccines, CDC and FDA closely monitor the safety of HPV vaccines after they are licensed. Any safety concerns detected with these vaccines will be reported to health officials, healthcare professionals, and the public. The link provides a recent summary of the safety evidence compiled by experts at the National HPV Roundtable. And with that, I'm going to turn the next portion of our presentation to Dr. Romesser.
Great, thank you, Lillian. And everyone, please use the Q&A to submit any questions that you have, because we're certainly looking forward to answering those at the end of this presentation. When thinking about, I know we have a mix of physicians, nurses, office assistants, and patients on the phone. And when we're thinking about intervening and bringing up the HPV vaccine to our patients, we have a few action points that we recommend. And the first is making a presumptive recommendation for cancer prevention. So all of us, no matter your role, your recommendation is powerful. Okay, and the recommendation is the #1 reason parents choose to vaccinate their children. So the studies have shown that presumptive statements, which are really brief statements that assume patients are ready to vaccinate, are more effective in improving HPV vaccination coverage than an open-ended conversation. So how do we do that, or what does it sound like? It sounds something like, now that your son or daughter is 11, he or she is due for vaccinations to help protect against meningitis, HPV cancers, pertussis, and flu. We'll give those shots during today's visit. And it shows that you're really putting just as much value on the HPV vaccine as the other vaccinations that the parent and patient are considering. And patients actually place just as much value on these as well. And it's important to present it as such. A second action is, of course, even with a presumptive statement, there's going to be questions. And parents look up to us as healthcare providers when it comes to their children's health. And, answering a parent's questions effectively, openly, and honestly is the first important step in building a trusting relationship. So after your presumptive recommendation, please be prepared to answer questions and inform your patients and their parents about the importance of the HPV vaccine. So again, emphasize that the vaccine is safe, effective, and prevents cancer. This is not a vaccine that needs to be stigmatized by, this is a vaccine for a sexually transmitted disease. This is a cancer vaccine, okay? So if patients question the need for the vaccine, something you can come back with and say is the HPV vaccine is important because it prevents infections that cause cancer, and that's why we need to start the series of shots today. If they're worried about the safety of the vaccine, you can say the HPV vaccine is safe. But yes, like any medication, vaccines can cause side effects. At times we can see pain, swelling, or redness where the shot was given, and that's normal for the HPV vaccine and should go away in a day or two. If patients are worried that their child is too young, you can talk about saying, we know it's safe to provide the vaccine from the age of 9. Adolescents demonstrate a robust immune response at this age. We want to protect your child before they're ever exposed to the virus, like we protect them from other vaccines. I recommend the HPV vaccine to all my adolescent patients. And remember the Scottish and Finnish studies that Lillian presented to you showing that robust immunity with earlier vaccination rates compared to later in life. And sometimes, this could be considered controversial, it's helpful, though, to give personal examples. So if it's true and if you're comfortable, you can even let patients know that you vaccinated your own child at age 11 to protect him or her against HPV cancers. A third action is about missed opportunities. So every encounter we have, again, no matter our roles as healthcare providers, is an opportunity to open discussion and to discuss. So to increase our HPV vaccination rates to be on par with other vaccination rates, we need to take advantage of these opportunities when we see our adolescent patients to offer cancer prevention. It's often not the first thing on their radar to be talking about cancer vaccines, especially as we're trying to get over some of the stigma surrounding HPV. So there are currently 3 HPV vaccines approved by the FDA, but it's easy because only one of them is currently on the market, which is Gardasil 9, which is made by Merck. This targets the high-risk HPV subtypes as well as multiple lower-risk subtypes that can cause other more benign diseases. So while there's multiple approved, your option for administration is one in the United States. HPV vaccination is really cancer prevention. As you've heard, boys and girls alike should be vaccinated against HPV, and the series should start early, around 11, and it can start as early as 9. It works. It works to decrease cancers, as we've seen. It decreases genital warts, and also has been shown to be effective. The main issue we're having now across the United States is vaccination compliance. And so this is why I and Lillian are so particularly grateful to be here with the AHEC group, is to raise awareness and help provide you with the tools you need to reach the patients. I want to switch a little bit to talk about anal cancer. You know, we're talking about HPV and a cancer prevention, so let's get a little bit of understanding of what one of these cancers may be. Now, cervical cancer, fortunately, in the setting of pap smears and cancer prevention, has dramatically dropped those rates in the United States. Anal cancer, on the other hand, the incidence is rapidly increasing despite it being a rare disease. So the risk of anal cancer is about 1 in 500. It's greater for women as compared to men, and the average age of diagnosis is in the early 60s. So there's a long latency often from when you get exposed to HPV to when you develop an HPV-related cancer. And that's why I made that comment when Lillian was presenting, that the fact that we already see a reduction in cancers in the FINISH study is incredibly promising, and we expect that to only increase with time. In 2020, according to the American Cancer Society statistics, we'll see about 8,500 new cases of anal cancer in the United States. Again, you can see the breakdown here, more common in women than in men, about 1,300 deaths, more in women than in men. Risk factors, HPV, HPV, HPV. That's why we're here talking about the HPV vaccine. There are certainly other at-risk or high-risk groups of individual. These include immunosuppressed individuals, so solid organ transplantation or HIV is also a risk factor. Chronic anal irritation or chronic inflammation is a general risk factor for cancer, and that is, again, seen here in the anus. History of other HPV-related diseases is an increased risk factor, and cigarette smoking with a correlation with duration and pack years. How does HPV cause cancer? I'm happy to discuss this at length, but the short of it is the HPV makes 2 proteins. We call them oncoproteins. These inactivate 2 tumor suppressors, the p53 tumor suppressor and the RB tumor suppressor. So it inactivates essentially 2 of the main barriers we have to cancer development. In anal cancer, HPV-16 is the predominant subtype that's diagnosed here, but we can also see HPV-18 in a small subset, and over half of patients, or the majority of patients, have more than one HPV subtype. HPV risk factors, multiple sexual partners. Why is that? Because that increases your risk of acquiring HPV if you're unvaccinated, anal intercourse, sexual activity at a young age, and condyloma, AIN. So what about HIV and anal cancer? And this is really a plug. If you have HIV individuals, you should be thinking about this, especially if they're telling you they're having bleeding or pain from the anus. So the risk of developing anal squamous cell carcinoma is about twice. And in fact, while HAART or antiretroviral therapy has really turned HIV into a chronic lifelong disease compared to what it was in the 80s and 90s, what it is it's extending the period of time where patients have some element of immune suppression. And so in contrast to other HIV-related malignancies, the incidence of anal cancer is actually rising, okay? So it's important to monitor these patients and consider this. And oftentimes these patients can develop recurrences earlier than some of non-HIV patients after treatment. So this was a write-up in the New England Journal from about 2 years ago talking about HIV-associated cancers and related diseases. And again, you can see it's not just anal cancer, it's actually all HPV-related cancers that are increased risk. So keep that in mind when you're seeing your patients. It's just a plug for more cancer screening and prevention. Anal cancer occurs through a continuum of dysplasia to moderate dysplasia, severe dysplasia, to in situ carcinoma, to invasive cancer, okay? This is the same continuum seen in cervical cancer, which is why you have the cervical pap smear as a prevention to it. So you're actually picking up pre-invasive cancers that can then be intervened on or monitored for clearance. And similarly, there is interest in anal cancer screening, but there's no published guidelines. And we did talk about, and admittedly, anal cancer is a rare disease. So the question is, what population of individuals are high risk enough where they would benefit from screening? And there's interest in ongoing trials evaluating anal pap smears and something called high-resolution endoscopy to identify new and novel ways for screening for anal cancer. And so hopefully more to come on this. Prevention. Well, one way for prevention is sexual abstinence. This generally is a very ineffective method of prevention. Most individuals get exposed to HPV in their late adolescence and early 20s when sexual promiscuity is high. And so despite this being a very effective measure at prevention, in the real world scenario, it's very hard to be an effective prevention despite what we all think, or what parents may tell you that their son or daughter is not doing X, Y, or Z. HPV vaccination is actually the best long-term approach for reducing anal cancer risk. If we could effectively vaccinate the entire population of the world with the HPV vaccine, we would reduce the incidence of cancer, any cancer, worldwide by 4%. That's a striking number that through simply vaccinating worldwide, we can decrease 4% of the worldwide cancer burden, okay? So we here already have, right now, low rates of HPV vaccination, and we should be leading this cause. The CDC, again, to summarize it, recommends routine vaccination with the currently available FDA-approved 9-valent vaccine in boys and girls alike at the age of 11 to 12. They can continue to be vaccinated through the age of 26 if not vaccinated previously. The vaccine is approved for individuals up to the age of 45 years old. Given the data in the UK Scottish trial, we do know that the effectiveness of vaccination in older individuals is less, and after the age of 27, if you are sexually active, it is possible and oftentimes likely that you've already been exposed to HPV. But that doesn't mean you're not eligible for vaccination. I would argue that from the age of 27 to 45, that should actually be a personalized discussion with your patients about the benefits of vaccination. We do know the vaccine is safe. We do know it's effective in patients. In patients. So you just have to discuss the variants of it.
So this is Lillian again here. So that's amazing. Thank you, Dr. Romesser. How amazing that that taking the vaccine can reduce the incidence of cancer worldwide by 4%. I mean, I wish I had that vaccine when I was growing up. So what I wanted to just touch upon, what I learned from speaking with physicians, scientists, and cancer survivors that applies to many cancers, is when I had anal cancer and I had gone through the 6 weeks of radiation and oral chemo, my white blood cell count was low naturally, and about a year later, it was about a year later, and it was still lower than the doctors had wanted it to be. And my oncologist recommended to take a supplement, which consisted of shiitake mushrooms, and I started to take that. It's called AHCC, which can significantly improve immune response. And I know supplements are loosely regulated, many of them making, marketing claims that are not based on science, but my experience is with AHCC, backed by over 50 PubMed index studies and clinically shown to accelerate the clearance of HPV infections, was really terrific. So I think it's, what I took was a diamond in the rough, and I started taking this. It's a mushroom root extract called AHCC, and, it's from Japan, actually, widely used, and in the U.S. for over 30 years with no side effects, so I decided to try it. And after taking it for about 2 months, I went into my doctors, and they said that my white blood cell count had gone up, where I didn't need to meet with a hematologist. So what I'm actually really even more excited about is that the University of Texas just completed an NIH-funded study which showed a 60% clearance after 6 months of use. That should be published in the early fall, and I'm very excited that HPV-positive women will have access to this amazing supplement from Japan. And now I'll turn it back over to Dr. Romesser.
Thanks, Lillian. That's a very powerful message.
Thank you.
When we see patients come in with a suspicion or concern or diagnosis of anal cancer, we take a full sexual history. We assess HPV and HIV risk. We'll do a physical examination. Here in this setting, we have to examine the anal sphincters, the anus, and the rectum. That's commonly done with a digital rectal examination. And we're assessing the sphincter function, feeling the groins for any lymph nodes, and we do a full exam on males and females, lab work, HIV status, and we do a colonoscopy to rule out any other colon disease, and then we do imaging for staging purposes. Anal cancer staging is done according to size of the primary tumor and if the lymph nodes are positive or not, essentially is what you need to know. How is anal cancer treated? Well, if you have an anal margin cancer, this is often treated as a skin cancer, and if you can surgically, if a surgical oncologist can remove the cancer with wide negative margins, that's sufficient to remove the cancer. Now, if that surgical resection is going to involve cutting into the anal sphincters or a procedure that's going to really affect the long-term sphincter function, then definitive radiation is recommended to essentially treat these and allow the patients to keep their normal organs intact. Adenocarcinoma of the anal canal is a very rare entity. These have a very negative prognosis. These are not HPV-related cancers. These patients should definitely be seen at a major cancer center. And for squamous cell carcinoma of the anus, again, chemoradiation is largely the primary treatment saving large surgeries like abdominal perineal resections for salvage or for local recurrences after if they are in the unlikely group that failed treatment. So, back in the 70s, 60s, 70s, the treatment for anal cancer was surgical removal of the anus and rectum. Patients were left with a permanent colostomy or a bag that now collected their stool. This surgery was effective and patients did well, but it really left patients scarred, physically scarred and emotionally scarred. You can imagine that having removal of your anus and rectum and placement of a permanent colostomy is a life-changing procedure, okay? And so at Wayne State, they did some studies, and here it's reported by Norman Nigro, where they actually evaluated radiation and chemotherapy in patients who either were not really well fit for surgery or who were not ready to accept the surgery. And what they found was that they effectively eradicated tumors in over 85% of patients with good survival and colostomy-free survival, meaning colostomy-free survival is being alive and without colostomy, okay? And that's what a lot of patients want to hear. They want to hear, what's my chance of being alive and with my anus and rectum intact? If we look at the NCCN guidelines, these are guidelines that dictate what we should do and how we should treat cancer. Essentially, these are the gold standards for cancer therapy. Again, we talked about the workup, and for local regional disease, the essential treatments are radiation in combination with chemotherapy. Again, surgery is reserved for the setting of excision, for the setting of salvage treatment. Okay? So locally advanced disease is associated with worse outcomes. This is a busy slide, but it's just to show you that if we look at survival or disease-free survival means being alive and without cancer anywhere in the body. What we can see is that these go down with increasing tumor stage or size of the primary tumor and when your lymph nodes become positive. And if we look at the risk of recurrence, so the hazard ratio is just the risk over baseline. So men have a 40% increased risk of recurring over women. If you have lymph nodes, your risk is even higher. If you have large tumors greater than 5 centimeters, your risk is even higher as well. So following up after chemoradiation, we generally see our patients back for a toxicity check at about 4 weeks. And we then follow them up about 3 months later to check to see if they're actually having what the state of their cancer is. So you don't check right away, and this is one of the interesting things of anal cancer. You want to give the radiation chemotherapy time to work. And this is not true of all HPV cancers. This is really unique to radiation. So if you look, at 1 month after chemoradiation, you would actually see residual tumor in a high percent of patients. But if you wait till about 3 months, you actually see there is most of the tumors have responded. But if you still have disease present at 3 months or 12 weeks, as long as the tumor is getting smaller, you continue to monitor the patients. In fact, if you look, there was a study called the ACT2 study. Patients who still have disease at 12 weeks or 3 months, if you check again at 6 months, over 70% of those patients will actually have their disease go away. So as long as the disease is heading in the right direction, it's okay to monitor. So these patients should really be monitored by providers who have expertise in treating and managing patients with anal cancer, okay? And we cure a lot of patients. And so what we need to do also is we need to place an emphasis on what we can do during treatment and after treatment to help patients have improved quality of life. So I refer all of my female patients to sexual health, women's sexual health group, which helps them identify vaginal and vulvar moisturizers and lubricants. We treat our patients with a vaginal dilator in place that pushes the sensitive aspects of the woman anatomy, the clitoris, and the clitoral hood away from the radiation field and reduces the radiation dose to these areas, which helps prevent long-term dyspareunia or pain with penetration. We also have our women use vaginal dilators routinely for the rest of life to help maintain the elasticity of the vagina. Men are referred to male sexual health. Oftentimes, I even prescribe men Viagra or Cialis to use during radiation. There's been studies showing that these agents can help decrease the risk of erectile dysfunction in the setting of prostate cancer. And so I'm extrapolating that data to the setting of anal cancer. And one thing that every patient comes back to and thanks me for is once they're fully healed and recovered, I send them for something called pelvic floor physical therapy. There's more muscles and intricacies in our pelvic floor than we ever thought, and this helps them retrain those muscles so that they can get really good control of their bowel movements. So really, just to conclude, multidisciplinary treatment modality is imperative. Here I manage these patients with my colorectal surgeon and with my medical oncologist. Chemoradiation with curative intent is our gold standard. And again, the goal is to cure the patient of disease and allow them to keep their anus and rectum intact. There are certainly remaining challenges: enhanced therapy for advanced disease, reduced therapy for early stage disease. There are 2 large cooperative group studies available in the United States at over 700 sites around the country. So there are great clinical trials that are being run by the National Cancer Institute for patients with anal cancer. And if anyone has questions about those at any time now or in the future, you can feel free to reach out to me directly.
So thank you, Dr. Romesser. So now we're going to present some HPV facts, but I do want to say that personally that I was so lucky to be treated by Dr. Romesser because I'm here today, and he is really just not only a wealth of information, but just wonderful, smart, and terrific doctor. Moving on. Fact 1, HPV vaccines are safe. More than 270 million doses of vaccine have been distributed worldwide, with more than 100 million doses in the U.S. Like with all vaccines, HPV vaccine safety is constantly monitored, and these studies continue to show that HPV vaccination is very safe. All medications and vaccines can have side effects. The most common side effects seen with HPV vaccination are mild and are very similar to reactions from other vaccines.
Thank you for those kind words, Lillian. That means a lot. And I do what I do for my patients like you and for patients all over the country to help improve outcomes after cancer. What's another fact on HPV vaccination? There's no data to suggest that getting HPV vaccination will have a negative effect on future fertility. If anything, vaccination is going to protect women against cervical cancer and help ensure a woman's ability to get pregnant and have healthy babies.
Okay. Fact 3, the HPV vaccine does not contain harmful ingredients. People are exposed to aluminum every day through food and cooking utensils. Aluminum-containing vaccines have been used for decades, given to more than 1 billion people without problems. In spring of 2000, the National Vaccine Program Office reviewed aluminum exposure through vaccines and determined that no changes to vaccine recommendations were needed based on aluminum content. The Global Advisory Committee on Vaccine Safety, part of the WHO, has also reviewed studies and found no evidence of health risks that would require changes to vaccine policies.
So the HPV vaccination is necessary regardless of sexual activity. So you really, people are vaccinated well before they're exposed to an infection. Think of measles or pneumonia. Similarly, we need to be exposed and vaccinated against HPV prior to exposure. So 11 or 12 offers the most HPV cancer prevention. And HPV is incredibly, incredibly common, and almost everyone will be exposed at some point in their life. So even if your child delays sexual activity until marriage or only has one partner, they could still be exposed if their partner has been exposed. And so it's really important and imperative. And there's really, studies have shown there's no correlation between receiving the HPV vaccine and anything like increased rates of engaging in sexual activity. And so if parents are concerned about that, please reassure them.
The HPV vaccine is for boys and girls. Both males and females can get HPV. It's very common, as we've been speaking about. Scientists estimate that between 80 to 90% of people will be infected with at least one type of HPV in their lifetime. HPV vaccination is strongly recommended. Vaccination helps protect boys from getting infected with the most common types of HPV that can cause cancers of the throat, penis, and anus. Although cervical cancer is the most well-known type of cancer caused by HPV, persistent infection is what I had, can cause several other types of cancer, including the cancers of the base of the tongue and tonsils. And HPV can also cause penile and anal cancers in men, as I mentioned. HPV vaccination helps prevent infection with the types of HPV, as I mentioned before, that cause most HPV cancers in men.
And just remember, from when you're infected to when you develop cancer has a long latency. So we're talking about vaccinating now to prevent this disease in the next generation. And so we're going to hear over our lifetime the rates of HPV-related cancers rising as individuals who were not able or offered the HPV vaccine because it wasn't available, it wasn't developed yet. We're going to see that coming up. So the baby boomer population right now, these are very high-risk individuals for developing HPV-related cancers. You've heard about many famous movie stars who've come out and said they have HPV head and neck cancer, such as Michael Douglas. You've heard about famous actresses who've come out and talked about the HPV-related anal cancer, like Marsha Cross. And we're going to be hearing, I expect, more stories like that, but that should not circumvent you or sway you from the effectiveness of the vaccine. This is a lag in terms of getting what we need. Okay, so just know that there's going to be a generation of protected individuals because they're vaccinated, and we're living in this time where there's a generation of unprotected individuals because they didn't have that vaccine at that time. So the HPV vaccine is effective and prevents cancer. To get to my next point, again, it's been shown through the multiple studies to prevent the infections that cause cancer. And again, the Finnish study showed that decreased rate of cancer that's only going to get more increased. And think about how stressful it is when you go and have a pap smear and you're told you have HPV, or you hear about someone who has HPV, or your son, or your daughter has HPV. How stressful it is. You got to come back, get retested. It's a very stressful situation emotionally. And so that's another thing that we're trying to eliminate, cancer and the stress around it.
Okay. An effective recommendation from a clinician matters. So an effective clinician recommendation recommending the HPV vaccine in the same way and on the same day as other adolescent vaccines is the #1 reason parents chose to vaccinate their children. Recent studies show that a patient who receives a recommendation from a provider is 4 to 5 times more likely to receive the HPV vaccine. Studies have also shown that parents value the HPV vaccine equally with other adolescent vaccines. In addition, parents want to prevent cancer in their children. So if you can try this effective recommendation, your child needs 3 vaccines today to protect against meningitis, HPV cancers, and pertussis. That would really make a difference.
And that's that presumptive statement we've been telling you about. And I think if you incorporate that, you're going to see a positive impact already in your rates of HPV vaccination in your clinics. And remember, each interaction with a patient is an opportunity to introduce this. The effectiveness of the HPV vaccination does not decrease with time. Studies have shown that the vaccine protects against HPV infections and cancer, as I've been telling you, and that this protection has been shown to last more than 10 years with no signs of protection waning. These are currently ongoing studies. If there is waning of vaccination, then that will then introduce the concept of a booster shot, which we've all heard about for other types of vaccinations. But at this time, there is no indication that the protection is waning, but that may change in time. But as of right now, you go through the series of vaccinations, and that's all that you need.
So in conclusion, HPV is a significant cancer and non-cancer healthcare burden. HPV vaccination is an important step for cancer prevention. HPV vaccination is most effective during adolescence, ages 11 or 12, prior to HPV exposure and infection. The CDC recommends vaccinating boys and girls as HPV is linked to cervical, oral, and oropharyngeal, anal, penile, vulvar, and vaginal cancers. HPV vaccines, VAX is a good resource for parents to obtain information on the HPV vaccine. That's at cancer.org. The CDC provides clear recommendations for practitioners that includes relevant and current immunization recommendations. So
Lillian is just an amazing individual, and I knew she was a very different patient from the first day I met her. And she not only persevered, fought, and conquered her anal cancer, but she has now taken a mission in her life to raise awareness around the country and, for that matter, around the world. And so Lillian's been doing a lot of just absolutely amazing things. She's the one who put this together and really coordinated this with AHEC, who's another outstanding organization. And it's just an honor for me to be working with both of them and to be able to talk with you today. And so with that, I'd like Lillian to talk about some of the work that she's doing, because I think it will be much more powerful hearing about it from her and not from me.
Thank you, Dr. Romesser. Thank you. Like I said, I feel so lucky that you were my doctor, really. So what am I doing now? So basically, just to kind of make it into a nutshell, when I got diagnosed, I was blindsided because many years that I've gone for Pap tests, I was fine. I was negative. And what happened to me was 3 years ago this time that I experienced some bleeding in the rectal area. It wasn't a lot, but it was consistent. And I thought, this is strange. And then I ended up going to my gynecologist, and my gynecologist said that I was fine. She said I was fine because my Pap test was negative. And I really, I said to her, I don't think so. I don't think I'm fine. And I pressed on, and I went to another doctor who actually ended up finding the tumor because he looked with an anoscopy, and he also palpated, and he felt it. I did go back to that gynecologist, who I actually really liked, and I said, I'm not blaming you, but hey, you missed this. And she said, well, it's not my area. And when I was waiting for radiation at Sloan Kettering here in New York City, I came across a few people, too many people that had the same answer, which was, yeah, you know, I had some blood and I went to the doctor and they said it was just a hemorrhoid, and now I'm, you know, stage 3 or stage 4, and it went to my lymph nodes. And I said, this is just not acceptable, and, you know, when I get better, I'm going to do something about this to get the awareness out, because the average person doesn't really know about that. They don't know enough about HPV that all of a sudden you're 50 or 60 and you wake up one day and you're told you have HPV-related cancer, and you're thinking, HPV? Well, I haven't had sex in 30 years, but it has nothing to do with that. It's a virus, skin to skin. So I decided to create and launch the HPV Alliance, Spreading Knowledge, Saving Lives, which we launched May 30th. And as my quote says here, although anal cancer is a rare disease, it's on the rise for both men and women, and unfortunately stigmatized so much so that many people will avoid even seeing a doctor. I know people who'd rather die than go to the doctor and have that kind of a checkup. We have to spread the word, because many people have never heard of anal cancer, much less HPV and the cancers it causes. HPV and anal cancer desperately need a voice, and I am that voice. So we've created the HPValliance.org, and there's a picture on the left, and that is our first board meeting, which took place about 3 weeks ago, when we launched the board meeting. And actually, Dr. Romesser is on the board, and Marsha Cross, the actress, is on the board, and we have a wonderful, diverse selection of doctors and thought leaders who are in this HPV space, and we're really going to make a difference. We're always looking for volunteers, ambassadors, so if you're interested, contact me at Lillian at HPValliance.org. I also was an ambassador for the Anal Cancer Foundation, and then I decided to launch my own organization, and I'm very, very appreciative that AHEC asked me to come and speak, and I'm really honored to be doing this with AHEC and Dr. Romesser.
I'll add in one thing, Lillian, because you brought the Anal Cancer Foundation. The Anal Cancer Foundation is an amazing organization as well. They have outstanding information for patients once they have anal cancer. It can help guide them to doctors who specialize in it, identify clinical trials, help support with logistics and whatnot. And they have, and they're excellent. And actually, there's organizations like that for just about every type of cancer. So if you have a patient who has any type of cancer and they're having a problem getting in to see a doctor, or they're confused, or they need to talk to a patient, or anything like that, look up the organization that does that and just give them the phone number. And I promise you, if they call that, they're going to get help and they're going to get connected. And these, I think, are a highly underused resource in American healthcare.
Yes, thank you, Dr. Romesser. You're right. And I have to tell you, when I went through this anal cancer, I was the type of person that actually wanted to know everything about it. I read the Farrah Fawcett book, she died of anal cancer. I wanted to know. And I asked, poor Dr. Romesser, I would sit there and ask him 20 questions each time. But when I did start to Google, I did find this Anal Cancer Foundation, analcancerfoundation.org, and they are a wealth of information, and they were just fantastic. And Justine, who heads up the foundation, is lovely, and they're just absolutely wonderful. So our mission at the HPV Alliance is to ensure early detection, to enable early intervention, enable early treatment of HPV-associated cancers by ensuring that doctors use the right diagnostic procedures to detect cancer early, prevent HPV-associated cancer occurrence advancement through regular HPV screening that enables early intervention. We really want HPV to be on the medical society's radars. We want the diagnosis of a hemorrhoid to be the last conclusion. Let's rule everything else out first. Ensure early intervention to enable prevention. Reduce cancer risk by shortening the duration of HPV infections through lifestyle interventions. Prevent HPV infections through vaccination. Here is a slide of some of the fun things that we were up to this past year. Right after my cancer diagnosis, right after I was finished treatment, up on the right, I had a kick cancer in the butt party, and it was so much fun. And honestly, what we did was we brought the level of stigma down by making it fun. We made it educational. If you look on the bottom right, here I am at an NCCN meeting in Florida with Justine Almada from the Anal Cancer Foundation. And if you see over there the little butt piñata that we hung up, I have to tell you, we were the star of the whole meeting. Everybody was coming up to us. All the doctors wanted to know what that piñata was all about. And then here in the middle, that's Marsha Cross and I. Last year, up on the left corner, both of us were at this Skate Your Butt Off event in LA that my friend helped me coordinate. Justine and I did this along with a few other organizations like Survivor and the Farrah Fawcett Foundation, and we did this big event, Skate Your Butt Off. And then on the bottom left, in the corner, are some pictures of Justine and I doing some presentations and also of the NCCN meeting. And then here I am speaking at the round table, at the HPV round table last year, their annual convention. And then we have some references here and some more references. And then we have a thank you. And if you have any questions, you can reach out to Dr. Romesser. Here is his email and then my information. And that concludes our part.
Yeah, why don't we move on to the Q&A? We've been getting some great questions coming in.
Yeah.
Everyone, please keep the questions coming in.
Very good. Thank you, Lillian and Dr. Romesser. Excellent presentation, and like you said, we do have a lot of questions, so we'll get started on those quickly. We'll also put up the post-evaluation, so just work through that as we move through. First question is the vaccine approved for people up to 45 years of age, and what is the effective rate for 26 to 45-year-olds?
Yeah, if it's okay, Lillian, I'll take that. So the vaccine is FDA approved up to the age of 45. We recommend completing initiating the vaccine at the age of 11. We is the CDC. It has nothing to do with me. Once you're 27 to 45, that's where the efficacy significantly drops down from the slide Lillian showed of the I forget which study it was, but it showed that it was 15% efficacy. So that's dropping down because many of these individuals have already been exposed to HPV, and you're also less likely to generate a robust immune response the older you get. So it is approved. I think, again, I briefly touched on this. I think it's a nuanced discussion for a 27 to 46-year-old. It is a safe, well-tolerated vaccine. So in patients who have, who had a low risk for HPV exposure previously and are, re-entering the world, let's say someone who was married at an early age, got divorced, and is now dating, that would certainly be an individual I would encourage to vaccinate, something like that.
Very good. Thank you. Next question. What is being done to reduce the long-term effects of radiation treatment for HPV-related cancers?
A lot. Radiation is excellent for treating cancer, but as I talked about the sexual and the pelvic floor physical therapy, it does cause side effects, and I see that every day. So we would like to decrease the rate of those side effects because patients do so well that that we really have to focus on their life and getting them back to functioning. So one of those large studies that I mentioned that's available all over the country, and that certainly we could find a place, is for patients with early stage disease who do exceptionally well with chemotherapy and radiation, looking to see if we can lower the dose of radiation to treat the anal cancer. So lowering the dose will result in less side effects, and we're hoping that it doesn't change the cancer outcomes. Similar studies are being done in HPV-related head and neck cancers where we're trying to lower the dose there as well. And what we find, just as a quick plug, is that HPV-related cancers actually don't need as much of a high dose as other type of cancers. You know, in the head and neck, you can have HPV-related or non-HPV tobacco-related, and the HPV-related do better, and they actually respond to radiation more favorably. And so we're doing the same in anal cancer. So it's an active area of investigation, and there's studies open around the country for patients who are interested in that.
Wonderful. Next question is related to the iceberg image of HPV cancers in the CDC handout. And are there any thoughts in editing the image, since oropharyngeal cancer is now a most common part of the cancer caused by HPV? I can share first, if you'd like, one point. Tomorrow I will be meeting with our HPV project officer, and I will be more than happy to bring that topic up. I will say to you that almost all of the CDC handouts that are available, and I'll be posting a link to some of their items for one of our next questions up in the chat pod. But those handouts are almost always changed every year. So the chances are very good that that will be updated.
Yeah, I love that question. I think it's great. Oropharyngeal cancer is taking off. I think the main reason why it's written this way is because cervical cancer and screening and HPV-related cervical cancer, that's what people are immediately associate with it. But you might be right that in the current day and age, maybe we're getting the message out about HPV, and now we're making the association with oropharyngeal, and I think that's a great suggestion.
Next question is regarding a child's pediatrician that is not very convincing about regarding the vaccine. They got the first dose, but then it had been 3 years to get the second dose. Can the third one be given, and if so, when?
Yeah, that's a good question. I would get the third one, and I would get it sooner rather than later. Just to help. You can also reinitiate the vaccine series if you thought it was done incorrectly. If on a separate note, I don't know if you have availability for other pediatricians in the area, but if it's a general issue that you don't feel that your pediatrician is on it, for lack of a better word, then I would encourage you to seek another pediatrician as well.
Great. And I'll be posting a link for a CDC reference to answering parents' questions about the HPV vaccine. And then there's also some how to recommend. So those of you who are health professionals can go check those out and learn some new skills on best ways to do things. Our next question is related to the supplement that Lillian mentioned. What is that again?
Oh, it's called AHCC. I can provide you some information on that. I can get you some specific information on it.
Great, thank you. Next question.
Sure.
How early should screenings begin?
Yeah, you know, screening in HPV cancer is controversial because of the low incidence of it. So, but you should, you know, many women are getting annual gynecological exams. I would hope that that includes a digital rectal examination. I read one message on the chat that said, I had a patient whose gynecologist diagnosed them with anal cancer and saved their life. I think that gynecologist deserves, you know, a huge hug and a high five because they're on it, and that's what we want. And I hear many women coming in from their gynecologists. Many men are getting digital rectal exams for prostate exams, things like that. So I think there's that prevention is on point.
Wonderful. Our next question, if someone has risk factors for anal cancer, how often should they be examined for that cancer? And should they only be examined if they have a history of cancer?
Well, that's another, the role of screening, and this is something where we got to do better on. Remember, the best dollars spent is not in treating cancer, it's in preventing cancer. So if anything comes of this and we save one patient's life, that's the best we can do. But, and that's also why the HPV vaccine is so effective. But if you're at high risk, I would definitely have a conversation with your healthcare provider, talk about this webinar that you just attended and say, could you consider at least screening me with a digital rectal examination? Now, most patients do present with symptoms, symptoms meaning bleeding from the anus or pain. And we have to applaud Lillian. She shared her story. She had bleeding and she knew it wasn't normal. And so she went on and requested more workup from another doctor. Mm-hmm. And so if everyone knows their body better than any doctor does. If there's something wrong, keep asking for it to be properly addressed, not letting it be shrugged off.
Very good. Next question. What is the most common anal cancer symptom before they come in for a diagnosis?
Bleeding and pain.
Okay, great.
But sometimes, let me interject, sometimes there are no symptoms. Like in the case of Marsha Cross, she didn't have any symptoms, but her gynecologist was astute enough to catch it, and she had no clue that she even had HPV.
That's another on-point gynecologist. So, again.
Yeah. Yep.
That's a great point.
Next question. What percentage of patients are not able to keep their anus and rectum intact?
Depends on the stage. But, if you're a T1, T2 node negative, so if you have a very small tumor, and these are the individuals who are eligible for the de-intensified treatment protocol or clinical trial I discussed, that's about north of 90% at 3 to 5 years, so really effective. If you have more locally advanced disease, you drop down to about 75 to 85%. So 3/4 of patients can keep their anus and rectum intact.
Great. Next question. HPV is a sexually transmitted infection, but is it transmitted only through sexual intercourse? How about other modes of transfer?
Lillian, you want to take that one?
Yeah. So here's my my take on that. HPV is a virus. So, you can get this. Actually, there's research and evidence now that you can get it from open mouth kissing. It's a skin-to-skin virus, not just necessarily from sex, as Dr. Romesser said earlier. You can use all the protection you want, but it doesn't matter because it's a friction thing. I have to tell you, one of my contacts is a 56-year-old detective from Long Island, and he's so annoyed that he got anal cancer that he wants to track down where he got the HPV from. And I said to him, "You're never going to know. You could have gotten this virus when you were in 6th grade, playing, spin the bottle." So, yeah, it's definitely just not from that.
Great, thank you. Next question is related to the HPV vaccine. Is it safe for someone who has already had HPV?
It is, yes. It is safe. The efficacy would be less. It's not, it can't, there's the data that the vaccine can help you clear prior infection is low. But it can protect you against other HPV subtypes that you haven't been exposed to.
And I did get the vaccine at age 53. I got the vaccine even though I already had HPV because I was single, and I thought, let me just get it. Maybe it can protect me against other strains. And I haven't had any issues at all.
How early should anal cancer and HPV screening begin?
Well, again, there's no anal cancer screening that's currently recommended in the United States. There are studies that are looking at individuals who have who are at high risk to see if screening can be effective in them. But being that said, there is HPV screening of the cervix, which is recommended in the United States. You can have, because I saw another question on the chat, you can have anal cancer and never have had a positive HPV on your pap smear. That can definitely happen. It's not common, but it can definitely happen. So that's not really HPV screening. That's cervical screening with HPV infection of the cervix. It's kind of a nuanced difference. But again, that's the setting where you're going to start to see much of the screening. And when you go for your annual examination, if you think you are at high risk, simply asking your doctor to do a digital rectal examination isn't unreasonable. There's essentially minimal harm in a digital rectal examination other than the unpleasantness of it.
Great, thank you. Next question. We have multiple questions related to the performance of digital rectal exams. Any kind of thought as to the types of practitioners who are doing those, the reluctancy of practitioners to do those, or are they becoming much more standard than they may have been in the past?
Yeah, I mean, there's always there's always a reluctance to do it. I think it's unpleasant on both sides of the bar, but it's an important aspect of screening, especially I think for high-risk individuals. There's also anoscopy and anal pap for extremely high-risk individuals, and I know Lillian and the HPV Alliance are trying to evaluate better ways to study this. A digital rectal examination is a good start. I would be happy to hear that gynecologists are incorporating this into their into the female exam each year. I've seen a few of the notes on the chat saying I'm doubtful that NPs and other gynecologists and MDs are doing this routinely. Some are and some aren't. I think the ones that maybe caught an anal cancer are certainly doing it because they know that they literally, probably significantly impacted that patient's longevity on the planet. So I think there's still a lot of debate about it. Again, there's minimal to no harm in doing a digital rectal examination other than the unpleasantness to the individual. It is noting that the anus has folds to it, so it's not like a simple 2-second examination. You actually have to, this might be too graphic, but you have to actually smooth out the anal folds as you're sweeping your finger around. A good examination should take about a minute, minute and a half, 2 minutes.
Great. And then since we're running out of time, one last question. And it's a question that I know from some other presentations we've given that a lot of people like to ask but are a little iffy as to if they want to do it. Is anal sex a prerequisite for anal cancer?
No, and it's not. During sexual activity, there's a lot of fluid and secretions all over the place, and in women, in certain sexual positions, those fluids tend to go backwards, and so those fluids likely contain, in infected individuals, high levels of virus. There's a postulation that men are more likely to get HPV-related head and neck cancers because fluids on them when they're performing oral sex are going into the back of the throat, and fluids during sexual activity with women are going to the back. It's not completely borne out, but it's been thrown around as a potential hypothesis. So the short answer is no. You could have never had anal sex in your life and get anal cancer.
Great. Thank you very much. Well, we have kind of met the end of our time, and I know all of you have lots to do, and the health professionals in our group probably have patients that they need to go see. But we want to first of all thank both of our presenters today for an excellent presentation and really a dynamic Q&A to answer a lot of things that people want to know about. So thank you very much. Another thank you to, of course, our High Sierra AHEC folks for bringing this opportunity to us, and more importantly of all, really bringing this to the forefront, sending out lots of emails, lots of passing on of the information to make it that it's okay to say that we went to a presentation on anal cancer. So a special thank you to them. Just a couple reminders. We did put up the information again about continuing education credits, which are available for physicians and nurses. And along with the nurses, there is a 0.5 pharmacology CE that's part of that. That is available. The information is there. You can also download the information. We also can provide a certificate if you need that, but you can also get a certificate with the CE credits. We do want to let you know that we're very sorry about the video. Every once in a while we test it, it works, and then all of a sudden it doesn't. So in a little bit, you all should be receiving, who have attended, a email from us that will provide you that link so you can go look at it right now and not miss anything and have it right after the event. So that should be helpful to you, and it will include some additional information. And then finally, we did have to go past a few questions that we knew would take a considerable amount of time to answer. So we will try to go through those questions and get some answers, and then also send that out to you post-webinar. We also will have the archive of the webinar together, so you probably won't get it in the next day, but at least in the next few days we'll have that for you. So I think I've covered everything. Again, thank you very much to everyone involved. This was very exciting. We look forward to doing more in the future. We just have a little scheduling hiccup between now and September, but we will send you notifications of upcoming webinars in September and October. Thank you again for coming, and thank you again to our presenters today and High Sierra AHEC. We hope that everyone has an excellent day and stay safe considering what's going on.
Thank you.
Thank you.
Thank you very much. Have a nice day, everyone.
Thank you. Thank you.